Welcome to today's deep dive. I want you to picture a scenario for a second. Imagine you're trying to neutralize a specific, highly dangerous target in a pitch black room. You have a flashlight, you sweep the room, and you finally spot it.
Okay.
But right as you step forward to engage, the entire room suddenly fills with thick, impenetrable smoke. Your flashlight is totally useless.
Oh, wow.
Yeah, you know the target is in there somewhere, but you are effectively flying blind. That incredibly frustrating and frankly terrifying scenario has historically been the exact challenge for interventional oncologists trying to ablate tumors inside the human body. They can see the cancer perfectly right up until the moment they start treating it, and then the biological smoke rolls in.
Right. The environment just changes instantly.
Exactly. But what if there was a way to make those cancer cells permanently glow in the dark, no matter what else was happening in the surgical field?
That is exactly the kind of disruptive medical technology we are unpacking today. For anyone joining us, whether you're catching up on the latest interventional techniques or you're just insanely curious about how human ingenuity is outsmarting cancer on a cellular level, this deep dive is going to completely change how you think about medical imaging and precision oncology. We're talking about taking the blindfold off the people trying to save lives.
Okay, let's unpack this. Our mission today is to explore peaky CT-guided tumor ablation. We are looking at how combining metabolic imaging with anatomical imaging is fundamentally revolutionizing percutaneous thermal ablation.
It's a massive shift.
It really is. To guide us, we're pulling from a brilliant 2025 special series review in the American Journal of Radiology by Drs. Paul Shin and Sharath Bhagavatula. And to give us the full landscape, because, no medical breakthrough happens in a vacuum, we're also looking at two expert editorial comments that debate the economics and the logistics of actually getting this tech into hospitals.
Which is always the hurdle, right?
Always. Let's start with the baseline problem. Why is the old way of doing percutaneous ablation so incredibly difficult?
To understand the breakthrough, we really have to look at the limitations of standard imaging. When an interventional radiologist performs percutaneous tumor ablation, the entire success of the procedure hinges on millimeter-perfect placement of the probes.
Like absolute precision.
Absolutely. Whether they are using microwave or radiofrequency energy to induce coagulative necrosis or cryoablation to create a lethal ice ball, the margin for error is essentially zero.
And that brings us to the fog of war. Before the procedure, standard CT or ultrasound is fantastic. The tumor is sitting there clearly visible. But the moment the probes go in and the energy is applied, the local environment goes completely haywire.
Exactly. The very act of inserting those probes and applying extreme temperatures immediately alters the tissue architecture. You're dealing with immediate edema and hemorrhage. Often, the operator is intentionally introducing hydrodissection fluid or air to displace adjacent organs.
Just to move things out of the way so they don't burn the wrong thing.
Right. Plus, you have massive beam-hardening artifacts from the metallic probes themselves on the CT. And with cryoablation, the ice ball is totally opaque on standard imaging. It completely eclipses the target. So right when you need absolute visual confirmation to ensure you're destroying the entire tumor, your visual field is totally compromised.
And if the anatomical distortion wasn't enough, there is a massive biological hurdle that the AJR review highlights, which is the shrinking target.
Oh, yeah.
When you apply microwave energy, the tissue doesn't just sit there, it physically contracts. The data they cite shows that during microwave ablation, tumors can shrink by an average of 45% in volume.
Almost half. It's a profound structural collapse. So you are trying to hit a bullseye that is not only obscured by artifacts and edema, but is actively shrinking to half its size while you are actively treating it.
That sounds impossible. So how have they been doing it up to now?
Historically, the workaround has been retrospective image fusion. The software takes the pristine pre-procedural scan and computationally registers it over the messy post-ablation scan.
Trying to line them up.
Exactly. But if the tumor has contracted by 45%, and the liver or kidney has shifted due to hydrodissection or even just respiratory motion, algorithmic registration often fails. You are comparing a map of a city before and after a major earthquake. The fiducial markers just don't align anymore.
And the clinical data on how often that visual estimation fails is wild. The review brings up a 2020 study where 38 interventional oncologists were asked to judge the success of an ablation using standard visual inspection. They misjudged whether they had achieved complete ablation 44% of the time.
44%. That is nearly a coin toss on whether the malignancy was truly eradicated.
Here's where it gets really interesting because the solution they've been developing is PT-CT guidance, and it essentially gives the operator a superpower. It completely bypasses the anatomical mess by focusing on metabolism.
It's a total paradigm shift. And it relies on radiopharmaceuticals, primarily FDG, which is a radioactive glucose analog, basically a radioactive sugar. Because malignant cells exhibit the Warburg effect, meaning they are highly metabolic and incredibly hungry for glucose, they aggressively uptake the FDG from the bloodstream. But because of its chemical structure, the cancer cells can't fully metabolize it, so the radioactive isotope gets trapped intracellularly. When you put the patient in the PET scanner, it detects the positron emissions. The tumor becomes a highly specific, glowing beacon.
The detail that totally hooked me on the logistics of this is the endurance of that signal. It isn't a fleeting contrast agent that washes out in 10 minutes. The FDG signal remains viable for 4 to 5 hours.
Which is a huge window.
Yeah, and even better, while the isotope does undergo radioactive decay, the standardized uptake value, which is the contrast between the tumor and the background tissue, actually improves over the next 2 to 3 hours. The background tissue clears the tracer, but the malignant cells just stubbornly hold on to it. So the longer the operator works, the higher the signal-to-noise ratio gets.
Which is the ultimate antidote to the fog of war we were talking about.
Yeah.
The PET scanner doesn't care about the edema, the hemorrhage, or the metallic artifacts from the microwave antenna. It ignores all the structural chaos and exclusively maps the trapped FDG. You have continuous, uninterrupted visualization of the viable tumor cells.
Dr. Shin and Bhagavatula provide a couple of clinical examples that really ground this. They detail a case of a 78-year-old man with recurrent non-small cell lung cancer. On standard unenhanced CT, his new malignancy was completely masked by radiation fibrosis from previous treatments. It was just a dense, morphologically ambiguous mass.
You couldn't tell what was scar and what was tumor.
Exactly. But the PT scan easily differentiated the hypermetabolic recurrence from the inert scar tissue, allowing for a precise trajectory. They also showed a 58-year-old woman with an osseous metastasis in her pelvis that was virtually occult on CT but clearly delineated on PT, enabling precise cryoprobe placement.
What's fascinating here is the mechanics of how they merge these modalities in the suite. You have a patient under general anesthesia. To get that sub-millimeter registration between the PET signal and the anatomical CT, the anesthesiologist induces a temporary apneic pause.
They literally stopped them from breathing.
Just for a bit, holding the patient's breath for 20 to 60 seconds. In that single window, the system acquires a rapid PET scan to localize the metabolic target and a rapid CT scan to visualize the probes and surrounding anatomy. Because there is zero respiratory motion between the two acquisitions, the spatial registration is flawless. You see the exact physical location of your probe tip resting inside the hypermetabolic core of the lesion.
So what does this all mean for the actual endpoint of the procedure? Seeing the tumor in the probe is great, but the goal is durable local control. And that brings us to the concept of the ablation margin.
The ablation margin is the entire ballgame in interventional oncology. Destroying the visible tumor isn't enough because of microscopic perineural or vascular invasion at the periphery. The operator has to induce confluent necrosis that encompasses the entire target lesion plus a continuous circumferential 5 to 10 millimeter margin of normal healthy parenchyma.
They need a buffer zone.
A definite buffer zone. If that margin dips below 5 millimeters at any point along the z-axis, the risk of local tumor progression skyrockets.
Verifying a continuous 5 millimeter margin in 3 dimensions while the patient is still on the table used to be the holy grail. But with intraprocedural PET-CT, the review outlines 3 specific strategies that operators are using to actually see and measure that margin before they ever wake the patient up. Strategy 1 is PTC-FU fusion. How are they executing this in practice?
This strategy leverages a contrast-enhanced CT immediately post-ablation. The operator administers intravenous iodine contrast, which perfuses all the healthy vascularized tissue. Because thermal ablation destroys the local microvasculature, the zone of coagulation necrosis shows up on the CT as a dark, unenhanced void.
The dead tissue.
Exactly. The system then fuses that dark ablation zone over the intraprocedural PET image of the still glowing tumor. The operator can literally pull out their digital calipers and measure the distance from the edge of the FDG avidity to the edge of the unenhanced void on every single axial, coronal, and sagittal slice.
And the clinical outcomes of doing this are incredibly validating. The review cites a 2021 study utilizing this exact fusion technique. It allowed operators to successfully assess the minimal margin in 95% of the targeted tumors. And the local progression stats are stark. If they confirmed a margin greater than 5 millimeters, local tumor progression was only 10%. If the margin was under 5 millimeters, progression jumped to 41%.
That's a massive difference.
It is, but here is the critical part. Because they had this data intraprocedurally, it prompted the operators to perform immediate overlapping reablations in 17% of those cases. They recognized and corrected a suboptimal margin in real time.
While the patient is still asleep.
Yeah. What about strategy 2? The literature refers to it as perfusion PE.
Perfusion PET is a brilliantly elegant physiological trick. You might think of it as the donut technique.
The donut technique, I like that.
Yeah, in this scenario, right after the ablation is complete, the operator administers a small supplemental dose of FDG.
Yeah.
Now remember, the original target lesion is still highly avid in the center from the primary injection hours earlier. The new supplemental tracer circulates and is taken up by the healthy surrounding parenchyma, say, normal liver tissue.
Okay.
But the zone of coagulation necrosis you just created has no blood flow. It can't receive the new tracer. So, on the monitor, you see a bright hypermetabolic center, the original tumor, surrounded by a dark photopenic ring of dead tissue, which is in turn surrounded by the bright normal background liver.
It's brilliant. That dark photopenic ring is the ablation margin visually manifested. If it completely encircles the central hypermetabolic focus, you have a perfect donut and you know your margin is intact. Okay, let's look at strategy 3. This is the split dose PE technique.
The split dose technique approaches the problem differently. Instead of just trying to visualize the necrotic void, it actively hunts for residual viable disease.
Looking for stragglers?
Exactly. The protocol involves giving a fractionated dose, a small amount of FDG initially, just to localize the target and guide the probes. Then the operator performs the thermal ablation. Immediately after the energy delivery is finished, they administer the remainder of the FDG dose, a much larger bolus weight, about 30 minutes, and then rescan.
Got it.
The physiological premise here is that any malignant cells at the periphery that survive the thermal insult will rapidly uptake that new, massive wave of glucose. If you see focal hypermetabolism at the edge of your ablation zone on that second scan, you know exactly where your margin failed and you know exactly where to drop another probe.
I love how these strategies turn the inherent biology of the malignancy into the mechanism of its own verification. But I want to push back on this a little bit because biological systems are messy. Doesn't inducing extreme thermal trauma cause massive localized inflammation? And inflammatory cells are also highly metabolic. Wouldn't that ruin the scan and create false positives?
That is exactly the kind of critical question that initially made operators skeptical. The assumption was that the acute inflammatory response neutrophils and macrophages flooding the ablation zone would aggressively uptake FDG and mask any residual disease.
Right.
But the clinical data shows a distinct temporal delay. The acute inflammatory uptake of FDG doesn't become statistically significant until 20 to 24 hours post-ablation. So during that immediate intraprocedural window, the 4 to 5 hours while the patient is on the table, the inflammatory interference is negligible. The hypermetabolism you see is residual tumor, not inflammation.
Okay, that clears up the inflammation concern. But there are other quirks in the imaging, right?
Yeah.
The review mentions something called linear pseudouptake. What exactly is happening there?
Linear pseudouptake is a fascinating artifact unique to this procedure. We discussed earlier how microwave ablation causes profound tissue contraction. Well, occasionally, the tissue retracts so aggressively toward the microwave antenna that it physically compresses and draws the previously distributed intracellular FDG closer together along the track of the probe.
Oh, wow.
Yeah, it concentrates the radiotracer. So on the PET scan, you suddenly see a bright linear streak of avidity right next to the antenna. To an untrained operator, it looks exactly like the tumor is seeding or tracking up the needle path. If you don't recognize that it's just a mechanical concentration of the tracer due to tissue collapse, you might perform an entirely unnecessary morbid ablation along the needle track.
That highlights how crucial specialized training is for interpreting these intraprocedural scans. So the technology clearly works, the biological workarounds are solid, and the artifacts are understood. The glaring question is, why isn't this the standard of care in every major oncology center right now? And this is where we transition from the science to the institutional realities. The logistics of implementing this are heavily debated.
Absolutely. The barriers here are largely structural and cultural, not scientific. You have to look at the traditional hospital hierarchy. Historically, molecular imaging PET scans handling radiotracers is strictly the domain of nuclear medicine.
Hmm.
Meanwhile, percutaneous interventions and anatomical imaging are the domain of interventional radiology.
Different worlds.
Totally different worlds. These are distinct departments with separate training pathways, separate billing structures, and physically separate suites in the hospital. Implementing intraprocedural PTCT requires these two silos to integrate. You need an IR attending performing the ablation in a PET suite, coordinated by a nuclear medicine physician, with specialized technologists handling the isotopes. It is a massive logistical and administrative headache for hospital administrators to unravel.
And beyond the administrative turf wars, there was a very real physical safety concern early on regarding occupational radiation exposure. When you inject a patient with FDG, they become an active radiation source. Interventional radiologists have to stand right next to the patient, sometimes for hours, manipulating probes. I would be terrified of the cumulative dose.
The fear was definitely there, but empirical dosimetry studies have largely put it to rest. They've meticulously tracked the exposure, and the data shows the primary operator receives an average of only 0.05 millisieverts per procedure from the PET radiotracer.
Which is practically nothing.
Very low. To give you context, the vast majority of the occupational exposure in these suites actually comes from the fluoroscopy, and the CT fluoroscopy used for real-time anatomical guidance, not the photons emitting from the patient. With proper shielding, distance management, and time optimization, the radiation risk from the PT component is well within standard safety thresholds.
Time optimization is a great point because workflow efficiency is another major sticking point for hospital admins. Does moving a patient in and out of a PET gantry and waiting for tracer uptake bottleneck the entire IR schedule?
The workflow studies cited in the review suggest it adds approximately 25 minutes to the total procedural time compared to standard CT-guided ablation. When you weigh a 25-minute intraprocedural delay against the clinical and economic cost of a patient presenting with local tumor recurrence 6 months later, requiring a whole new workup, a second procedure, and vastly increased morbidity, that 25 minutes is an incredibly sound investment.
If we look at the two editorial commentaries we included in our sources, they perfectly encapsulate this exact tension between the undeniable clinical efficacy and the systemic friction of implementation. And just to be clear, we're looking at these editorials impartially to understand the current discourse in the medical community. Dr. Nasir Rostambeji takes a very measured, data-driven public health stance.
Yes, Dr. Rostambeji acknowledges the elegance of the technique, but he argues from a macroeconomic perspective. He points out that PTCT suites are incredibly expensive capital investments. Before we advocate for this as a universal standard, he wants to see multi-center randomized controlled trials proving that intraprocedural PTCT doesn't just improve technical success on the table, but actually extends overall long-term progression-free survival. He's asking for hard cost-effectiveness analyses to justify tying up a premium diagnostic scanner for a 2-hour interventional procedure.
And on the other side of that debate, you have Dr. Konstantinos Sophocleous, who takes a much more immediate patient-centric view. He argues that achieving ablation, which is complete macroscopic and microscopic eradication with clear margins in a single session, is the ultimate predictor of survival. If PCT is the best tool to guarantee that ablation, then the logistical hurdles shouldn't dictate patient care.
Right, because PC scanners are becoming ubiquitous in comprehensive cancer centers anyway. In his view, the ability to definitively verify your margin before the patient leaves the suite fundamentally shifts the risk-benefit ratio, and it should be adopted as the standard of care without waiting a decade for survival data to mature. We connect this to the bigger picture. It's the classic tension in modern medicine, standardizing a costly innovation versus optimizing individual outcomes. But even while that administrative debate rages on, the underlying science of molecular imaging is already evolving past the limitations of FDG.
Right. Let's talk about the horizon, because while FDG is fantastic, it's a blunt instrument. It just highlights glucose consumption. Not all malignancies are hypermetabolic, and some benign processes are. The review delves into next-generation, targeted radiotracers that are highly specific to tumor biology. For instance, they discuss gallium-based tracers that specifically target somatostatin receptors, which is a game-changer for localizing well-differentiated neuroendocrine tumors that might otherwise be invisible on FDG.
And beyond receptor targeting, they are looking at tracers like FAPI, which targets fibroblast activation protein. Instead of targeting the metabolic pathways of the malignant cells themselves, FAPI targets the tumor microenvironment, the structural scaffolding that the cancer coerces the body into building. For certain histologies like early-stage hepatocellular carcinoma, FAPI demonstrates superior lesion-to-background contrast compared to FTG. You are imaging the tumor's infrastructure.
This raises an important question, though. No matter how targeted the radiotracer is, we are still bound by the physical hardware of the PE scanner.
It's exactly. Current clinical PTTT systems have an inherent spatial resolution limit of roughly 4 to 5 millimeters. Due to positron range and detector physics, if a cluster of viable malignant cells is 2 or 3 millimeters wide, it suffers from partial volume effects and may simply blend into the background noise.
It just gets lost.
Right. For evaluating a 5 millimeter ablation margin, current PT is excellent. But if the goal of oncology is shifting toward eradicating every last microscopic focus of disease, we have to push beyond the physical limits of positron emission.
And that is exactly where the review ventures into what feels like sci-fi territory: optical molecular imaging and theranostics. Instead of relying on radioactive decay, researchers are developing injectable agents like plasmonic or iron oxide nanoparticles. You engineer these nanoparticles with targeting ligands so they specifically bind to the membrane receptors of the malignant cells.
And because it's a theranostic agent, it provides both diagnostics and therapy. You use high-resolution optical imaging to visualize exactly where those nanoparticles have accumulated, down to the cellular level. Then, instead of inserting a microwave probe that ablates a 3-centimeter sphere of tissue, you apply a specific, externally generated wavelength of near-infrared laser light or an alternating magnetic field. Whoa! Yeah, the nanoparticles themselves act as microscopic thermal antennas. They absorb that specific energy, undergo rapid excitation, and induce localized hyperthermia. You are literally cooking the malignant cells from the inside out, while the adjacent healthy cells, which haven't internalized the nanoparticles, remain completely unharmed.
It is the absolute pinnacle of precision medicine. You transition from regional coagulative necrosis to initiating a targeted thermal reaction at the single cell level. To bring it all home, the trajectory we've explored today is staggering. We started with interventional oncologists operating in the fog of war, battling artifacts and shrinking tumors, misjudging complete ablation nearly half the time. We looked at how mapping metabolic pathways with intraprocedural PPCT clears that fog, providing stable, continuous visualization for hours. It enables operators to utilize real-time fusion and perfusion techniques to verify a definitive 5 millimeter safety margin. And while the hospital administrators figure out the billing and the suite logistics, the science is already paving the way for targeted nanoparticle thermal interventions.
For you, the listener, understanding this intersection of cellular biology, radiation physics, and interventional technique is crucial. It pulls back the curtain on the incredible precision of modern oncology. Whether you're working in the field and navigating these multidisciplinary transitions, or you're simply fascinated by the bleeding edge of medical technology, grasping how we manipulate metabolic pathways to guarantee surgical margins empowers you. It highlights the sheer brilliance and relentless iteration of the tools we are building to dismantle this disease.
It truly replaces the fear of the unknown with a profound sense of awe. I want to leave you with a final thought to mull over. As we march toward single-cell resolution, utilizing optical probes and targeted theranostics to hunt down individual malignant cells, it raises a complex philosophical question for the future of oncology. If our diagnostic imaging becomes so exquisitely sensitive that we can detect a single, viable, aberrant cell floating somewhere in a patient's lymphatic system, at what point do we redefine what it actually means to be cancer-free? Does visual confirmation of every single microscopic flaw change the very concept of a clinical cure? Or does it risk creating an impossible, anxiety-inducing standard for the human body to ever achieve? Something to think about the next time you hear about a leap in medical imaging. Thank you so much for joining us on this deep dive. We will catch you next time.